Good evening. My name is Will Hand. I'm one of the anesthesiologists in Charleston, South Carolina. I'm giving the last lecture. It's going to cover goal-directed therapy outside the abdomen. I found out moments ago that some of my slides were stolen by Tim Miller and just shown to you. So I will repeat and discuss with caveats some of the very relevant work that overlaps. This is a unique way of addressing goal-directed therapy, I believe, because outside the abdomen, there's a paucity of consensus data. There are a lot of pilot studies. At ASA, we come together, and this is an opportunity for investigators to see a patient population, to identify a methodology, and to consider investigating the best way to manage patients outside of abdominal surgery, which I think we can agree we have a good set of recommendations. Similarly to the previous speakers, I do have disclosures with a couple technology companies. And I'm going to build upon the physiology, the technology, and a lot of the data that was presented moments ago by all the speakers. I believe we have considerable momentum currently with the goal-directed therapy, the ARIS protocols, perhaps even Obamacare is some of the impetus. We know what we can do inside the abdomen, and now we as anesthesiologists are charged with trying to extrapolate and apply similar, not necessarily the same, but similar protocols throughout the body. So briefly, I'll move through orthopedic surgery, vascular surgery, and much of the data I present with vascular surgery does include some major abdominal surgery due to the nature of, for example, liver transplant and how to characterize those. And then at the end, I'll spend 7 or 10 minutes discussing microvascular surgery, perhaps the most unexpected bastion of goal-directed therapy. It is also my clinical and research interest, and so being our national convention, I have the opportunity to show to you guys some of the preliminary data on our study, which we just concluded last month. Orthopedic surgery is a very worthwhile group for us to invest in for several reasons. Obviously, we have older patients with ASA 2, 3, and 4. Currently, there's considerable variability in the overall anesthetic techniques, combinations of regional, perhaps no strong consensus for fluid management, let alone general versus sedation. However, the CDC showed there's a huge number of patients coming through our operating rooms every day, more than 1.5 million on an annual basis. So if we can figure out ways to optimize the outcomes of these patients, the financial, the social, and the labor-related burdens will be tremendous for us as a society. The first study I'm going to talk about is from Susan Sinclair, who looked at volume optimization in patients presenting with femur fractures. Her protocol used the esophageal Doppler and in a way that was very similar to what we would inherit on a daily basis. She had no ability to affect the pre-operative resuscitation efforts, which at my hospital is usually a lot of fluid, and inherited the patients at the time they came to the operating room. All the patients were under general anesthesia, had a nerve block or nerve catheter. The control group in most of the studies that I'm going to talk about, and there are several because there are small studies, are all going to be getting fluid in what is basically an unguided or relatively uncontrolled methodology, but specifically not technology or protocol driven. The intervention group used esophageal Doppler in looking at flow times and stroke volumes. Not surprisingly, the treatment wing of her study had an increase in the stroke volume, whereas the control group had decrease in stroke volume and cardiac output. These are two obvious proxies for tissue perfusion and oxygen delivery. The protocol group had shorter lengths of stay in all different categories than the control patients. Similarly, there were fewer complications. Those two results will be repeated in most of the studies I'm going to discuss.